Okay, let's get started. Well, welcome everyone to our semi-monthly seminar series. Today's topic will be the Maternal Child Health sponsored Biodesign Faculty Fellows here at Stanford. And the topic title is Designing Innovations to Improve Healthcare and Healthcare. We have today two of the Associate and Assistant Directors, Ryan and Janene, as well as some past and present faculty fellows. Our current fellows are HyeRan, Choo, and Dayal, and our alumni are Anita, Honkanen, and Tulio, Valdez. But just a little bit more background on today's session. So the idea is that the Maternal and Child Health Research Institute annually sponsors faculty fellows at the Center for Biodesign here at Stanford to spur innovations in maternal and child health. This program is offered annually, which Janene and Ryan will give you a little bit more background on. The fellows learn about the process, designing cost-effective solutions and preparing to implement those to change care. We'll talk about the education and training opportunities offered through Biodesign today, and you'll hear from some of our past and present alumni. Okay, well, here are some of our upcoming talks so everyone can kind of look and see if there's something that interests them and mark their calendar. We have this information up on our website. You can sign up there or look for some of our emails if you're on our mailing list. Next slide, please. And our big event coming up in October this year is our 4th annual symposium. We'll have a variety of topics and seminars and poster processions, but our keynote speaker we're really excited about, Kelly Mole, who's the Deputy Director of Reproductive Health Technologies at the Bill and Melinda Gates Foundation. She also used to work for the March of Dimes, and just very excited to have her. And her topic of conversation for the keynote will be Global Priorities in Reproductive Health Technologies. So mark your calendars for that. That's Thursday, October 28th. And you can sign up probably around August, September, but mark your calendars as a save the date. Next slide. So just for kind of some awareness, MCHRI offers a few resources for folks that are interested in health technologies and therapeutic development and clinical research. We have our Clinical Research Support Office, which connects to Stanford Children's Health, which provides operational informatics, regulatory, and other support for execution of studies within the Children's Hospital. So if there is a need there, please go on our website and learn more about that. Next slide. And then we also have a drug and device development service, which helps and guides investigators through the maturation of breakthrough therapies through proof of concept studies and commercialization. And you can find more about that on our website as well, if that's something that interests you. And next slide. This is something we do really appreciate folks when they take the time to do this, but please fill out the survey that you'll receive after this seminar. And I think we're excited to get the talk going. So as stated, we're going to hand this over to Ryan, who's the Associate Director of the Biodesign Faculty Fellowship, and Janene, who's the Assistant Director. So without further ado, Ryan, take it away.
Great. Thank you, Grant, and it's a pleasure to be here, and wanted to first start by thanking MCHRI for your continued partnership in driving high quality healthcare innovation for maternal and child health. And as was alluded to, this is such a rich area of need for health technology innovation, and to have the support of MCHRI year after year in promoting this and promoting this to our faculty trainees has been incredible. And I'm excited to share with you all of the presentations today to show just how creative and important a lot of this work is on an ongoing basis to impact patient care. Wanted to spend a bit of time just talking about the Biodesign program for those who are not familiar. And then I will pass things over to Janene to talk a little bit about the Biodesign process to health technology innovation, as well as to let you know about the Biodesign Faculty Fellowship itself. And we are coming up to our next cycle of recruiting for the coming year. So if you're interested, we'll have some information on how to learn more and how to apply to be part of the fellowship. And then, of course, our presentations from current and alumni fellows will be really nice to see, both work in progress, but as well how projects have matured over a few years of time. The Biodesign program was started at Stanford more than 20 years ago at this point by several of the Silicon Valley medical device innovators, largely in the cardiovascular space, with a thesis of needs and value-driven healthcare innovation. And our vision at the Center for Biodesign is to be a global leader in advancing health technology innovation to improve lives everywhere. This is a shot of our faculty fellowship class, and you can see Anita in the center left there, who will be joining us by video today. If you move to the next slide, please. The faculty fellowship was really started to address an unmet need that we saw at Stanford. And over the 20 plus years that Biodesign has existed, we've developed curricula and deployed them from our what we call our flagship postdoctoral fellowship, which is over the course of a year, to undergraduate and graduate courses. But the gap that we saw was that there was really no way for Stanford faculty who had an interest in health technology innovation to become part of the community and to learn this process of health technology innovation. By the numbers in the program, we have the technologies that have been developed in Stanford Biodesign as a whole have included 51 companies that have been spun out to develop those technologies. Almost $1 billion in funding raised. And the most important statistic that we always focus on is the number of patients that have been treated through technologies developed in the center. And right now that number keeps going up, but we're at 3.4 million at the latest census count, which is an amazing testament to the impact that the program is having. We've now on the BFF side trained 74 fellows over the last 7 years. And we train people who are very new to Stanford and those who have been at Stanford for their entire careers. And that crosses every single faculty line, both from the schools of medicine and engineering. We, of course, are very focused on diversity and inclusion. And have trained 19 women in the program, and always work to improve that, as well as 10 engineers. What that means is that the vast majority of our fellows are from the School of Medicine, but we always welcome individuals from the School of Engineering to participate as well in a truly multidisciplinary way. And you can see that we've got a nice swath of specialties, and that we've trained faculty fellows from just about every department in the School of Medicine, as well as from engineering, both on the adults, and then again, thanks to the support of MCHRI, increasingly with a focus on pediatrics as well. And next slide.
I'm gonna bring it back over.
So with that, I wanted to pass things over to Janene Fuerch, and I think many people on the Zoom today know Janene from neonatology, and also a director in the program that we co-lead together. So I'll pass things over to you, Janene.
Thanks so much, Ryan. So I wanted to briefly just talk about the biodesign process, and this is a very, very brief overview, but just to dip your toes in the water. So the 90% of university programs actually take technology and then go searching for the clinical need. And biodesign is the complete opposite of that. So we spend an enormous amount of time looking at the need and trying to truly understand the most compelling unmet clinical needs, and then use that to design the appropriate technology that really serves this population. And if you listen to my grand rounds the other week, then you'd understand why this is and why this is so important in pediatrics especially, and maternal health, because these areas are underfunded, under-resourced, and also really need a very clean and crisp process to make this happen. I just do want to pause for 1 second and say, there are needs everywhere, and these clinical needs we see very easily, especially as physicians. However, really understanding a need, I think I always tell the fellows this right in the beginning of the course, but they never believe me until about halfway through, really takes an enormous amount of time, because it's not just understanding and identifying that there's a need. You need to understand the landscape around that. From multiple different perspectives, the stakeholders, how that fits into the business world to be able to get this product to your patients. And certainly we use medical devices every day, so many of us need to understand this process from idea all the way through commercialization. And spending a lot of time understanding the need early on saves you a lot of time in the end. Make sure you have that need right, because this is really something you're probably going to be doing for the next 10 years. So we take design thinking, and if you guys are familiar at all with the D School here at Stanford, they have a process that involves empathizing and defining, ideating, prototyping, and testing. Integrate that in a user-centered way to the entire user of healthcare, which of course involves FDA and regulatory and reimbursement, insurance, Medicare, Medicaid, Medi-Cal, the American Medical Association, Obamacare, well, maybe we'll have Biden care soon. And to deal with all that complexity, we take that and we put on the biodesign process. So this is a very repeatable process that involves identifying unmet needs, screening them, allowing them to compete with one another, then spending some time on the invention stage. So before this, they're completely solution agnostic and we're just focusing on the need. Invent, and then move to the implementation phase, which we initially develop strategies within this program, but won't necessarily get to much of this stage until after the process, after the fellowship is done. So bringing this back to the actual fellowship, we start in October. We start kickoff sessions. And we spend a lot of time in clinical immersion. So spending time in areas that are not your clinical specialty, or if you're not a physician, then spending it in the clinical environment. Do needs finding exercises, meet monthly in November and December. Then in the winter quarter, which we just finished last week, we spend all of this time just on the needs process, finding, screening. And then the spring quarter is more on concept generation and screening, as well as starting to understand the IP, regulatory, reimbursement, business model, and that landscape, how it applies to your specific concept, bringing in experts from all around Silicon Valley. And so just to highlight here, I'll highlight, this is our website at the bottom. I'll put this in the chat as well in case you want to apply. The application is really simple. It's the easiest one you've probably ever done. There are 2 questions, and then that is due on May 9th. We're going to have an information session on May 5th, which you can sign up for. So look out for those announcements, but you can also sign up on the website. Interviews around May 12th to 14th, and then our kickoff session will begin in October. We do this early enough so that you can start to plan your schedule for the year, because they are every Wednesdays from 5:30 to 7:30 p.m. that you'll need to block off for that whole period of time from January through June. So we're thrilled if any of you want to join. If you have more questions, feel free to reach out to Ryan or myself or any of our former BFFs as well. So now it is my great pleasure to introduce clinical assistant professor of surgery with plastic surgery, but she's also a wonderful orthodontist who has done amazing things in our NICU and is one of our current BFFs, Dr. HyeRan Choo.
Hi, my name is HyeRan Choo. Thanks for the introduction, Janene. I'm craniofacial facial orthodontist, and with the interest in the airway. So thank you so much for the opportunity to present what I have learned so far through the MCHRI sponsored Stanford Biodesign Faculty Fellowship. So primary interest is the advancing the treatment option. Oh, you see my screen, by the way? No. Okay. So the primary interest is in advancing the area of the treatment options for the obstructive sleep apnea from infants to adults, and then regardless of the age and despite the nature of heterogeneous endotypes of OSA. Most often, the primary obstruction occurs at the level of tongue base while asleep. So, so my need statement is a way to resolve airway obstruction while asleep in patients with a tongue-based obstructive sleep apnea in order to reduce obstructive respiratory events. By definition, OSA is a clinical syndrome of respiratory disturbances due to upper airway obstruction. And there are 4 major endotypes, such as high pharyngeal collapsibility, which is related to the narrowness of the upper airway, and then low arousal threshold, which fragmentizes the breathing and sleep, and then high loop gain related to the instability of the central chemoreceptor sensitivity, and low response of the major pharyngeal dilators to respiratory stimuli. And more often than not, the OSA is attributed to more than one endotype, and the primary obstruction site is actually soft palate and tongue base. However, when the tongue obstruction is eliminated, the soft palate obstruction is often resolved or reduced, which makes this stats here is more confusing to interpret. The OSA is prevalent in 1 to 2% of infants and 2 to 5% of children, and more than 10 to 12% of adults in general population. And in infants, this OSA can be life-threatening and often accompanies failure to thrive. And in children, up to 50% of them who had a surgical removal of adenoid and tonsils still have residual OSA. And in adults, the gender discrepancy or the BMI predilection disappear as the people get older, over age 50 years. For existing solutions, mainly targeting to reduce the pharyngeal flexibility using positive airway pressure, and then removable oral devices to bring the lower jaw forward, and the positional modification and weight loss programs, and also surgical maxillomandibular advancement as well. The new kids on the block include quite a few drug trials. For example, Isoflurane increases the arousal threshold and helps people improve sleep quality despite the obstruction still remains unchanged. Cetizolamide, for example, decreases the relative apneic threshold by increasing the blood acidity and prevents the central chemoreceptors from overreacting to the low carbon dioxide level below the apneic threshold. So the patient won't lose the desire to breathe. Atomoxetine and then oxybutynin, the combination actually controls the norepinephrine uptake during non-REM 3 sleep stage, and then also prevents the acetylcholine release during REM stage. So these drugs together maintain the tone of major pharyngeal dilator muscles while asleep. And behaviorally, there is an effort to increase the functional residual capacity. And the expiratory residual volume, or there is an effort to kind of change the lifestyle to improve the tongue muscle tonicity while the patient is awake. And electrophysiologically, electrical stimulation on the hypoglossal nerve is also gaining popularity. So the need criteria in terms of innovation of medical devices for the future, I thought it should include 4 must-haves and 4 nice-to-haves. So basically, it should be effective as current positive airway pressure devices or hypoglossal nerve stimulation surgery in terms of reducing the AHI or ODI. And also it must be no surgery or minimal surgery. And then it must allow comfortable sleep through the night. And also it should be safe, comparable to the PAP therapies as well. And 4 nice to have would be easily adjustable and titrable, easy to use by patients and caregivers, and it looks nice or almost invisible, and durable or easily replaceable to a new device. So based on this, I'm in the process of brainstorming and prototyping potential solutions, which will be continued during the spring quarter of the fellowship. But the questions to answer as a next step would be, should sleep endoscopy be always included in the process of OSA diagnosis? And also, is there a way to modify the design of infants' preepiglottal button retainer more applicable for the older population? And also more in-depth research on the current hypoglossal nerve stimulation algorithms and how to improve them. So that is it so far. And thanks again for the opportunity to present my progress through the Biodesign Faculty Fellowship. Thank you.
Thank you so much, Dr. Choo. We're really looking forward to seeing all the ways that you bring orthodontics into our practice as well. So next up is Dr. Dayal. She's actually quite new to Stanford, so some of you might not know her, but I think she's going to be a leader in innovation. She's a clinical assistant professor of general pediatrics and also one of our current biodesign faculty fellows. I'll just add that, we were hesitant to show our solutions that are being developed. They're working very hard on those throughout the process. They're only halfway through because you really want to file appropriate intellectual property protection prior to showing those. So they've been advised not to.
Great. Thanks so much for the introduction, Janene. I will share my slides. Okay. I'll just Okay, so my name is Dayal. I'm a general pediatrician here at Stanford. And I want to thank MCHRI for giving me the opportunity to participate in this program. For anyone who's been interested in thinking about biodesign, I would go ahead and apply. This is probably one of the best things I've ever done so far in my career. So as they kind of alluded to initially, it's kind of like a stepwise process, which we're learning. And the first process is needs finding. And one of the needs that I identified was medication ingestions in children. So in 2019, there are actually over 1 million calls to poison centers for children less than 5. And 92% of the time that medication ingestion occurred in their own home. And 80% of the time, these kids are actually less than 3 years old. And 70% of the time, the medication actually belonged to their own parent or grandparent. This is another graph that I came across, which was pretty startling to me. This is emergency room visits for pediatric patients who are poisoned by prescription opioids. And, as you can see in this corner here, it really emphasizes that it's the kids less than 3 to 5 years old, which are really being impacted that we have to remember. So this is the #2 reason for ER visits behind sickness. So every 10 minutes, a child is going to the ER, and that's cost almost $210 million to the hospital every year. So this call to action has been recognized by all of our pediatric academic societies and also by industry as well, which brought me to my need statement of a way to prevent unsupervised medication exposures in children less than 5 years old in order to decrease the number of visits for toxic ingestion. And so the next stage we go into is like need screening. So at this point, I'm just going to talk to you about all of the research that I've been doing about this need. So we all know child-resistant packaging, the push and turn or push and pull, but it's really not enough. What I found out is that child-resistant packaging, it's actually testing children 42 to 51 months old. But as we saw in the previous graphs, 80% of these kids are actually less than 3 years old. So there is a gap there. And also interestingly, a child less than 5 years old, they have as much torque in their finger, in 3 fingers as an adult does with 2. So that might be a reason why they're able to get into medications in a bottle. But we also have to recognize 50% of the time, kids are finding these medicines anywhere we keep them. You know, if we accidentally drop them on the floor, in our purse, or even in a pill organizer, which we all know doesn't really have any safety features at all. This was a great article from JPEDS, and what they did was a poison control center, I think in Nevada. And every time a call came in, they asked a bunch of questions about the circumstance. So it turned out that when there was a medication exposure, a third of the time it happened from a prescription in a child-resistant container. A third of the time it was an over-the-counter. And then the other third was that had no child-resistant protection, like a vitamin. But I think what also is compelling that if you have a prescription, 50% of the time the ingestion came directly from the bottle, but 50% of the time we removed it, as you know, was shown in the prior slides, versus something like Tylenol or Motrin, where most kids are getting this from the bottle itself. So if you have a medication organizer, the odds are 2 to 1. If there was a pediatric ingestion, the child got it outside of the organizer. And, you know, unfortunately, a lot of our grandparents use these, and those are kind of the most dangerous drugs, or the one pill can kill drugs, such as beta blockers, diabetes meds. And then the PRN meds, like, you know, OxyContin or Adderall, those are more likely to be put on our nightstand so that we can remember it easily, since you don't have to take it every day. So if you think back to my need statement, I said how to prevent unsupervised medication exposures, which is really hard, right? Like, this is life. Kids are curious and they explore. And I think what we have to do is really think about, like, you know, our mantra, kids are not little adults, right? If we think from their perspective, they explore the world orally, visually, they put everything in their mouth. One day they're crawling, one day they're standing, one day they're pulling to stand. And it's those moments that these accidents happen with medications. So if we had to think of, like, what would I want in a perfect solution? So these are some of the things I've been thinking about. Must-have criteria is adhering to the current child-resistant packaging criteria without making it harder for adults. Incorporating some sort of unique pediatric knowledge. And then the last two are related to this picture. So if you don't put the cap back on the bottle right away, that's the prime opportunity for a kid to snap a pill. Or if it drops on the floor, you don't know how many are there. So I'd be interested in something that automatically re-engage resistance after every use, and also a controlled dispensing medication.
Janene, Anu?
Yes. Okay. And then nice to haves are, you know, something that could accommodate single versus multiple pills, portability, secure access to multiple adults. If there's only one person who has access to Motrin in your house, it's going to be a problem. And then some sort of medication or organization reminder. So another part we do is, like, what is the gap right now? So outside of, you know, pill bottles and blister packs, you know, we have all these organizers, which are great, but they don't have any safety protection. We have really great stuff like this, which, you know, has a padlock. You know, so you have to remember another code. It's only available to one specific person in the house. And then you have these, which are, you know, expensive, and they're great as well. But when you open them, they still kind of look like a candy store to a child. And then one of the final things we do in this process is think about, you know, it's not just the kid at home. Who are the people involved? So you have, you know, the house, and you have a kid ingesting. But, you know, we have to think about, there's FDA, there's pharma involved, there's pharmacy who dispenses meds. Over 4.7 billion meds are dispensed each year with child-resistant packaging. And then you have the insurance company who is the payer when you have an ingestion, but they also pay for the pills. So we are going into our next phase right now, and I'm excited to continue learning and getting great mentorship from everybody. So thank you.
Great. Thank you, Anu. Now we have a presentation from Anita Honkanen. And Anita, for those who were at the seminar last year, provided an update, and she has continued work on her project. Unfortunately, cannot be with us today, but was kind enough to provide a video. So with that, I will start this video and hear the update from Anita.
Good afternoon. I'm Dr. Anita Honkanen from the Division of Pediatrics in the Department of Anesthesiology, Perioperative, and Pain Medicine. Before I begin, I'd like to thank Mary Leonard and the Maternal Child Health Research Institute and my chair, Ron Pearl, for their support of my participation in the Biodesign Fellowship last year. And thank the Biodesign Department for the extension funding that allowed me to develop my idea further. Now, last fall, while investigating possible gaps in the healthcare system, I met the nurse manager of the CVICU. She told me about a patient admitted that morning at 4 a.m. who had been in the OR since 6:30 a.m. the prior morning. He was now on ECMO, intubated, and on pressors, and had not been moved during his OR stint, nor since he had been in the ICU for over 10 hours. There were a total of 9 patients on ECMO that afternoon in the ICU, all at extreme risk of developing pressure ulcers, and all at great immediate risk of cardiovascular instability related to any motion meant to decrease the formation of ulcers. I realized that despite focus for decades, the problem was still unsolved, and that all effective solutions required a set of staff to move the patients regularly, at least every 2 hours, something that's clearly impossible in the OR and often unsafe in the ICU. Now, the key factors associated with formation of pressure ulcers are delineated here. Many of them are exacerbated by time in the OR, particularly by long procedures associated with large fluid volumes, tissue edema, and unusual postures meant to optimize surgical exposure. While the factors remain the same, the most frequent site of injury varies between adults and children, related to the relative body weight in different areas of the body. So the head is more heavy in children, the sacrum area is heavier in adults. Pressure ulcers are categorized by depth and degree of tissue involvement, with the critical threshold for excessive pressure being around 10 millimeters of mercury, which is the pressure at which capillary closure occurs. This analysis resulted in this news statement with a focus on prevention or improvement in degree of injury in patients during periods of complete or relative immobility, such as that experienced in the OR and ICUs. The must-haves are those things I deemed critical to include in any solution. The nice-to-haves are things that would be useful and perhaps increase adoption of the product, but lack of any of these would not be deal breakers. Here you see my concept design with focused pressure relieving pads, utilizing alternating pressure supporting grids that are driven by an air pump. Now, here are the 5 main areas of concern from a business perspective. 2 of the categories are shown as green. The planned business model would begin as a razor and blade approach with some capital equipment to drive pressure reducing pads and some disposable pieces that would be used once for any given patient. The regulatory approach is relatively straightforward, given that this is likely a Class 1 device, but with clinical evidence of efficacy, there could be predicates available for a Class 2 filing under 510K application. Now, the 2 areas that I deemed at greatest risk were the technology and the intellectual property. I did file a provisional patent last September, and now we'll talk a little bit more about the technological risk mitigation. So here you see the 5 key questions that I thought I needed to answer, which I began working on over the summer using the extension funding. How to mold the balloon device, what materials to use, what design to create, how to seal the balloons, and how to test the device. Now, I spent did a lot of iterative working in my garage over the summer, and this slide kind of summarizes it all. Many hours of months over several months, many hours of work over several months. In the upper left corner, you see a vacuum molder that I purchased, and it's set up in my garage. The things on there are one of my first attempts to look at actually what's called a male model, where the sheet of plastic coming down molds over the device. On the upper right corner, you see several different designs that I was practicing using the mold with, made out of pressure board. I started with just a simple grid to try and understand how the plastic would mold in different shapes, either a male on the left or female in the middle. You see the balls pointing up, or the holes in the design. In the bottom of that section, the round things were the first attempts at the head support device that I ended up really focusing on. Bottom left, you see there was a lot of work done on how to seal a balloon. I was very frustrated for quite a while about this, but eventually got something that really worked well. I had a mold made when we got finalized, and I finalized the design. You can see it better in the upper left corner, that white circular mold. That was made for me by a machine shop in the Midwest. And then I had to figure out how to seal that well. The original approach I was using with a soldering iron didn't work well on this intricate a design. So I ended up getting a aluminum plate made by the same firm in the Midwest, and then using an iron and several layers that were specialized to prevent the wrong things from sealing at the wrong times. I got something to work. Then I had to start testing, and you see in the bottom right a couple of the things I've done with testing so far. One is just lifting, proving I could lift a weight off of the surface, and that worked actually quite well. I jury-rigged a sphygmomanometer and am able to lift a 6-pound ball off of the desktop there, using the design with just half of the balloons inflated in one series, and then the other half gets inflated in the second. And then I've got some pressure paper, pressure sensitive paper, that clearly shows that the balloons that are not inflated do not have much pressure, and the balloons that are inflated relieve all of the pressure. So strategic planning are my next steps. I'm going to continue to finalize the patent application over this year, begin to get some fully working models, working on the insufflator part of the design, get some funding and do some testing, both on volunteers and hopefully clinical testing, and then I'll be on my way. So hopefully at some time in the future, you'll see this daisy head cushion or some form of this, supporting children and adults to prevent pressure ulcers. And it's still a problem. I just saw a patient of mine had some trouble after a prolonged neurosurgery. So I think hopefully we're on our way to a solution. I'm sorry I'm not able to be there in person today, but if you have any questions or would like to talk to me more about my project, I'd be happy to do that. Please email me. It's my last name, HONKANEN @stanford.edu. Thanks again.
Great. Well, certainly appreciate Anita making the time to prepare that video in advance. And I have to say, parenthetically, that Anita has had perhaps one of the most thoughtful approaches to prototyping her solution. And what I think everyone can appreciate is how easy it is to really prototype things from just around the house or the garage that help to answer really key questions about a design, how it works, how it feels, its function. And that's been a tremendous example of that has continued through her project. Now it's my pleasure to introduce Tulio Valdez, another BFF alumni, or alumnus, I should say, from the Department of Otolaryngology. And Tulio, really looking forward to hearing your update.
Thank you so much, Ryan. And I would like to reiterate that doing the Biodesign project was one of the best decisions of using my time here at Stanford. As an otolaryngologist, I face the problem of otitis media almost on a daily basis. And we know how difficult it is to diagnose. And so my need statement was a better way to diagnose otitis media in pediatric patients in order to reduce unnecessary treatment. And by that, I mean antibiotic prescriptions and placement of ear tubes. So otitis media is extremely common, yet it's very poorly diagnosed by conventional otoscopy. There's over 8 million cases each year in the United States. However, the success rate for pediatricians and primary care physicians normally is about 51% in infants and about 60% in toddlers, which is not great. Despite that, the number of antibiotics that are prescribed is significant, is about 14 million per year. And one of the biggest problems is detecting the middle ear fluid is very difficult. Even in studies that have shown that otitis media has been diagnosed, they've noticed that there's no fluid when at the time of tympanocentesis, which is making a little incision in the eardrum to confirm the findings of fluid. Otitis media is also the most common reason for surgeries in pediatric patients under the age of 15. So a little anatomy to go over is everybody's seen the ear on the outside, but when you look inside, there's the external auditory canal, and that tympanic membrane separates the external auditory canal to the middle ear, where actually the infection happens and where the fluid accumulates, and then you see the inner ear. So to be able to diagnose otitis media, you have to look at the tympanic membrane and actually see through to what's happening into the middle ear. But as you can imagine, that tympanic membrane, even though it's semi-translucent, is not transparent. So light gets scattered and light gets reflected back, and it's not really easy to see if there's fluid or not present. In general, otitis media is nothing more than fluid in the middle ear. Our technology has really not changed much since the 1860s. When I look in my office, tomorrow I'll be using this exact otoscope, which is nothing more than what was used in the 1860s, a light bulb, a magnifying glass, and a speculum. And this is basically what happens when kids present with fever. They'll complain. It's very difficult to see because they're crying. They may go to a urgent care center and may require some antibiotic treatment. And if they keep having these problems, they may end up needing ear tubes. So there's a couple of different technologies that have been described. The otoscope, the tympanogram, which is basically what we use nowadays. Now there's some phone-based otoscopes and recently a product just approved by the FDA last year, which is OCT, but it's extremely expensive. So with that in mind, we created some must-haves. We wanted to have a product that was between 2,500 to 5,000, easy to use, that there's some quantifiable effect, because right now it all depends on human interpretation. And we wanted a better sensitivity than 75%, which is the highest we get when an otolaryngology looks at the ear. Nice to have some kind of diagnostic output and be able to see through wax and have a being portable. So it all came down to the fluid problem for us, and we wanted to be able to look at the ear. So we came up with this short-wave infrared imaging, because in a way, fluid gets absorbed differently in the short-wave infrared, and is able to see through thin layers of tissue. Initially, one of the problems was the cost was extremely high, but that has changed because they changed the way they manufacture these sensors. So before they were almost made in an artisanal way. Now they just use the common silicon sensors, and they put quantum dots on top, which is a lot cheaper. So that lowered the price significantly and allow us to have an alternative to the OCT and to the ultrasound and to the common otoscope and other sensors. The big highlight here is that middle ear fluid looks black and it gives you much more contrast. And we could see it here on this design. You could see when we inject fluid in this model on the visible, and this is how that same model looks on the shortwave infrared. It's significantly more contrast. And we've already started trials in our patients, and you could see a normal ear, which we could see through the eardrum, see the ossicles.
2 minute Tulio.
We see a patient with fluid, which is a complete blackout. We've already applied for the patent, which got awarded. And it's a type 1 device. We're on our prototype number 3 at the moment. We're collaborating with a group from Germany and with a company that makes otoscopes at the moment. So we've basically right now have over $300,000 in funding for our next prototypes. And we're still doing some basically de-risking the device at the moment to make sure that it can make it to the market. We're still looking very hard into that reimbursement strategy, mostly because the OCT device was able to create their own CPT code. And since we can image similar to the OCT, we may be able to do something similar. Thank you.
Great, thank you, Tulio, and congratulations on the project, and thank you for sharing it with us.
Thanks.
Thanks so much, everybody. We really appreciate it. Please feel free to post some questions in the chat. We'll just give a moment for that kind of to take shape. But would love to kind of circle back to HyeRan and maybe Anu, and just, what have you appreciated thus far about the faculty fellowship program? And, as you kind of look for the next stage, what are you hopeful for? So maybe HyeRan or Anu. HyeRan, since you're off mute, do you mind going first?
Sure. Do you hear me okay?
Yep.
So before I started this fellowship, I thought it was, whenever I had some idea, wow, it's a great idea, I need to work on it. But after following through step-by-step education through this fellowship, I realized there's so much more that I need to know before jumping into kind of prototyping. And so it was very hard. So prototyping is a fun part, but before that, getting to that level, realize there are a lot of reality checks, and then you really need to know about that disease in depth before you make a commitment. So that's so far I realized it, and I'm very thankful for slowing me down and then go through each process. I think it's this great experience that definitely repeatable, and in the future, I think I will go through each step properly, so that I wouldn't the risk of making a premature decision is going to be much lower. So that's what I'm most appreciative so far.
Thank you. And Anu?
Yeah, I would echo everything that she said. I think, as clinicians, we see kind of problems every day, whether it's it's a medication ingestion or just our patients even getting to the pharmacy to get a med. And the great thing about this program is it helps you figure out, okay, what is this need? And then let's think about it from a business standpoint. Who are all the people involved in that? Is this a need that addresses a big enough market? I think, I always see all these innovations in heart disease, which is fantastic, but as a pediatrician, I know kids need this too. And I think I really appreciate the support from this program on how we can also bring pediatrics to the forefront of medical device innovation.
Thank you. And Tulio, I think, just it's so impressive, and Anita as well. But since we have you here, when you finished your fellowship, how'd you keep yourself motivated to keep going? And, you're at such a critical stage that I think everybody's really excited about now as a potential benefit to our patients. But how'd you find the motivation, and how'd you develop the collaborations to kind of make that successful for your product?
So in a way, being involved as a clinician and seeing this problem over and over again, it's what motivates us. You want to find a solution, and you want to be able to deliver it to the people. So it's that's basically what makes you find the time and reach out to people to move things forward. Actually, part of the Biodesign, Ryan and Janene are amazing. Whenever you have a question, you could just email them and talk to them and come up with ways, ideas, and solutions to the problem. So yeah, I'm extremely grateful to the program.
Thank you. I don't see any questions in the chat, but Janene, you have one?
I was just going to highlight some of the questions that Ryan and I were answering as we went on, just in case people didn't see them, because I think there's some really good ones in there. Dr. Gary Darmstadt asked one question, which is how much time per week should you plan? And I was remiss to say that it's about 10 to 12 hours a week, and to acknowledge that this really is an individual project-based fellowship. So it's not just that you come in and you listen to us talk and then you walk out of the room. It really is what you put into it, you get out of it. And so you have to attend a 2-hour session, which is on Wednesdays from 5:30 to 7:30 p.m. So if you're interested and you need to change your schedule, we ask that you do block that time out for the duration of the course, because we have experts that come in as well that are giving their time for us. And then there's additional time that is necessary for looking at all the reading, going through the videos, and preparing the weekly deliverables, which definitely take time. So 10 to 12 hours is realistic, but it does take 10 to 12 hours too. So I just at least wanted to highlight that. There'll be more on that during our information session on May 5th if you want to sign up, and we can go into the details. We really wanted to highlight the wonderful work that our Biodesign faculty fellows are doing in this session, but happy to answer those questions at any time.
Great, thanks so much. Just got a question. So how far along should you be in a particular project or an idea, and in order for you to be able to apply for that fellowship? Is there like any phase, or what do you guys think?
That's a great question. I'm glad it was asked. And in Biodesign in general, we actually ask you not to come to the fellowship or any of our training programs with a solution. It's certainly okay, and as Tulio pointed out from the issues that you see every day in clinic, certainly okay to come with some ideas about needs and unmet needs. And that can extend both clinically, and in some cases, there are research questions as well that come from that. But in general, we are going to start the curriculum and the training with evaluating and vetting those needs, and going through a process that will allow you to hone those needs and identify a need that is worth going after. You have to recognize that any technology that is going to reach patients is probably on average a 5 to 7 year endeavor. So you want to figure out, is this a problem worth solving before you get into any of that time, money, personal investment in a particular solution. Now, that said, we understand that faculty in some cases do have research programs or projects that are existing where they are getting ready to commercialize. And this is kind of the one exception that we make in Biodesign, that it is okay to bring those solutions into the program. We will bring you back to the need that you are trying to solve and have you walk through that entire process with us. And our experience in that regard is that it's actually really brought together many of the fundamental questions, honed the need, and gotten those projects in better shape for translation. But those, I would say, are more the exception than the rule, where we ask you to come in with more of the need than the solution.
Thanks so much, Ryan. And I don't see any other questions, but just wanted to take this time and thank both you and Janene for being on. And we thank you so much for the partnership between MCHRI and Biodesign. And just want to thank our speakers again. Just making a mental note, everybody get excited for the first couple weeks of May if you're thinking about applying, please apply. We're so thankful for our fellows and love to see all the innovative work that they're doing. And just also want to give Ryan, you and Janene just a last couple minutes to say anything if you'd like.
Well, I would just thank you again for your partnership and for the opportunity to be with you all today and to share some of these great projects and innovations.
Don't hesitate to reach out to either of us or any of your former BFFs if you have questions. We're always happy to do that and have those conversations.
Thanks so much, everyone. And please remember to fill out the survey, and hope you have a great rest of your day. Take care.